All right, I think we'll go ahead and get started. And so this is the much postponed series on careers, and we thought it would probably be appropriate if we can get the career section in just before graduation. But people's minds are really focused on what they're going to do with the rest of their life in order to pay off their loans millions at a time. So we're really happy to have some great people to come up and be with us today. So I'd like to start. We have three people. We have Carolyn Nichols from Interaction. If you haven't met Interaction, if you haven't met their website, this is a good acquaintance to make because there's a lot of really interesting and valuable information, a lot of resources on that site. Then we're happy to have Lara Ho, who's with IRC. So then we have Lara Ho with the International Rescue Committee, and the students with tenure can remember Lara when she was a doctoral student here, and we're all happy to have her back again here. And then we have Linda Mobula, who's going to talk in the end. And Linda did her MPH here, now works with the Office of Foreign Disaster Assistance, and Linda and I have worked on multiple projects together over the years. So I've asked Carolyn if she would start off, maybe start off with a little bit of YouTube clip here, but also to give us a kind of general overview of what is actually happening, where are the opportunities, where are the needs, and so forth. And as a way of introduction, I'll say that Carolyn is in Interaction in the advocacy. And Interaction is an association of American NGOs, I think 180 or some now, and it's responsible for coordination of response for humanitarian assistance. So it's very much focused on humanitarian assistance, although it has people that do cows and various other things as well. And she's looking at how to put together some of the global health debates. And if you haven't been watching anything going on in this country in the last few minutes, there's a lot of global debates going on right now, so there's a lot of things to talk about. She joined Interaction after having 9 years of experience working in Pakistan and also in the North Caucasus area. And she's had experience in the Middle East as well, and I could go on at some length, but I won't. And Carolyn will turn the time over to you, so give us a little bit of an introduction here, and then the time's to you.
Like any good academic setting, we're going to start off with a video. You're supposed to laugh. Thank you for accommodating. It's only going to get worse. So do I need to pull it up?
Yeah, you have to pull up something here, whatever you want.
None of these are my video.
Oops.
How did this work so easily yesterday? Why don't we try this? Getting closer. None of these are it.
If you put on your channel though, is it uploaded with Interactions? You kind of need to do this.
Oh, right. Okay. Hold on.
Okay, well, you're going to get
Don't do that. I mean, we can go through the picture tour if you wish, but that's kind of defeating the purpose. Let's see it here. Ah, here we are.
Okay, great.
Finally. Okay. we don't do health. Hold on, let's not go to another film here. Oh, we're definitely not doing that. Okay.
Everyone, and welcome to the
Again, we're not doing that. So, cool. So I am not a health professional. I have a master's degree in international affairs with a concentration in socioeconomic development. And I ended up in all of these post-conflict crisis-affected places. So, but I work with a lot of health professionals, which I guess is part of the reason why I'm here today. I wanted to talk a little bit about interaction because it's kind of a unique entity. A little bit about what we do in terms of humanitarian policy and practice. And then a teeny smidge about how I came to be in this role and where health interlocks with that. And then things to do look out for as you are continuing or launching into a new phase of your career. Yeah? So Interaction is a largely US-based NGO consortia. It's really interesting. Most of our members are development actors in orientation, but we have about 40 or so really active humanitarian or multi-mandated members. It's really interesting. So we're a membership organization, so our members need to meet certain standards of transparency and accountability, as you guys just saw. But we're also kind of a trade association where we are a platform to convene members around specific issues, whether they're country-based or thematic, such as the Ebola crisis, such as health in general. We also work to be greater than the sum of our parts, right, in terms of the US NGO community, amplifying that voice. There's always a tension and not really a rhyme or rhythm, but it seems to work out between where we want operational voices in terms of global policy fora and where our members want interaction to show leadership on specific issues. Yeah? Vague enough? Good. So I work on our humanitarian policy and practice team. I've been there for about 5 years. I came there from the field. Actually one of our members from the International Rescue Committee. I actually work on humanitarian policy within our humanitarian policy and practice team. We work in a couple different sectors, not health, we'll get to that. We look at protection, we look at practice, how can we improve our efficiency in the field, work better together. We also work on shelter, and we do a bit around security practices within the NGO community. We are always looking at how the field practice of humanitarian action can influence global policy fora and vice versa, right? So a large part of our role is making sure that field voices, and particularly those representative of NGOs, are represented in global policy discussions. Yeah? So one example of that in the health realm, after the Ebola crisis, the World Health Organization worked on developing SOPs to better respond to pandemics on a regional scale, right? Again, we are not health experts in and of ourselves, but our members are. So we facilitated and supported member engagement in global policies, in part, well, largely led by the World Health Organization, to make sure that NGO perspectives, because NGOs are the implementers, right? They need to have their voices heard. So we supported NGO engagement in that policy development. And in fact, are continuing to support as that policy is being tested, as it is in the next couple of months. So a little bit on that. How did I come into this position? As only would have happened in the 1990s, and I'm sure that a few of you remember those years, I got a fellowship essentially for public diplomacy, where I was one of 10 high school juniors who were allowed, I guess, or facilitated to spend a summer in the Middle East. So 10 high school juniors, Syria, Jordan, Israel, Palestine, one chaperone. Again, that would only happen in the 90s. fell in love with the Middle East, started working in conflict resolution, moved on to the policy realm and the think tank community in DC, the Council on Foreign Relations, felt that the policy world, at least in the think tank community, was kind of devoid of the human voice. Those policies weren't being developed for people. So then I moved into the humanitarian world, going to graduate school at the New School in New York, and then between my 2 years of graduate school, got an internship with the International Rescue Committee. They put me wherever they wanted to put me, and that happened to be the North Caucasus, which was post-conflict at the time, even though we don't really use that term anymore. And then was with the IRC for 5 years, doing various things, including grant management, which led into managerial roles, right? So a little bit about that. Grant management is a great entry place if you are figuring out your way into the humanitarian world. Why is that? So as a grant manager, well, it's three things actually. You do a lot of proposal writing, which is a great skill to have, and a skill that's transferable to a lot of different roles. You do a lot of report editing. If you go to the field and you are really entry or mid-level, you're going to do a lot of English language editing. And this is not really shared in advance, so here's the spoiler alert. And you figure out donor guidelines, which is really an important thing which you'll have to understand if you move into the policy realm. And it's really interesting to figure out what experiences and practices how those guidelines came to be, right? And that's really interesting to then move into an implementation role. Grant management is an excellent way to move into a sectoral expertise, right? Whether it's education, whether it's health, whether it's livelihoods. A lot of these sectors are interconnected, and you learn a lot from each other. So, there you go. Three things so you asked me to talk about what's needed. We need people in the field, yeah? One of the things that will distinguish you the most as you're looking for jobs is if you can show that you've got direct field experience. It doesn't matter what it was, right? The fact is that you were out there learning and supporting people, no matter the organization. Field experience, critical. Three key things about getting onto the job market, in my humble opinion. Be adaptable, be flexible. No career path turns out exactly as you think it's going to, yeah? Be humble, be mentally nimble, listen, ask, speak with integrity, say what you mean what you say, observe and listen. Having great writing skills opens doors in ways that great writing skills open doors. Be willing to take risks. Be willing to move to a country that you've never been to before. Be willing to go to a country that you never had thought of going to before. Be willing to do things that are perhaps a little bit uncomfortable for you. But make educated decisions, of course. And play well with others. Yeah? Cool. Well, that's what I was going to tell y'all.
Thanks very much. So I think we have time before Carolyn sits down to take any kind of questions, maybe a few minutes, 5 minutes of questions. And if you have additional questions that exceed 5 minutes, we'll take them at the end. So maybe I can start off, Carolyn, you say obviously you're not in the health area, but you have a lot of health units and so forth. You're involved with health organizations. Where do you see the emerging kind of needs in the health sector?
I actually would defer to my two colleagues here on that one.
Well, I'm going to ask them the same question.
Okay,
so.
great. I think we found, and again, my colleagues might have a different perspective on this, but I think we found, we had a conversation with our advisory committee as the Ebola response was really kind of midstream, if you will. And we asked them what their number one challenge was. And it was getting sufficient staff to the field. And that's why I say, go to the field. Go and get field experience. And to a degree, it kind of doesn't matter how you do that. You will probably have to go in a generalist capacity, and that's okay. But field, I think getting people with field experience who can translate that experience to the global level and back is incredibly important.
What would you consider sufficient field experience?
Well, it depends on what you want to do and what you're trying to do. I think, well, we'll put it to you this way. When I was going to Pakistan, sight unseen, I was told, you can survive anything for a year. Yeah? So, and I stayed for 3. It was great. So I would say get at least a couple years in if you can. Get to know a place.
Especially for the person who is applying perspective as a public health professional,
Uh-huh.
what kinds of specific skills do you require, like with the or
I'm going to defer to my colleagues who are public health specialists. I'm not a public health specialist, so I can't really answer that question, and nor have I hired them. I've hired folks who do emergency response in the health sector, and those who have kind of niche expertises, right? But they're not public health specialists per se.
You said you worked with ICRC, right?
International Rescue Committee.
Okay.
Yeah.
So having a second language, was that?
I've been lucky in that I haven't had to use languages too much, but always learning the local language is a great icebreaker and great for relationship building, even if it's not critically necessary.
So when applying, though, I guess, to these organizations, I'm kind of wondering how big a factor having a second language and which second language.
It depends a little bit on where you are in your career. If you are, say, in the first, I'd say 5 years of your career, having a second language is really helpful and will set you apart, particularly in places where that's necessary. I mean, look at Francophone Africa. You cannot get in unless you speak French.
Okay, thank you very much. I'm not going to ask you to repeat the thing about being able to write proposals, because people have already heard that one so many times. But I think we'll now go on to talk, to hear from Lara. And Lara Ho is now with the International Rescue Committee. She joined them in July 2007, and she's worked in Tanzania, Cote d'Ivoire, DRC, Chad, Myanmar, Sierra Leone. I think there's another 2 paragraphs here. At the current time, she's based in Washington as a senior technical advisor dealing with health research issues. So she's an RN by background. She did her PhD here, focused on research issues, and now is in a situation where she can continue to carry on in the same direction that she has in the past. She's been a Peace Corps volunteer in Mongolia, interesting place, and and she finished her PhD here, as I said before. So Lara, let's hear from you.
I think Caroline covered most of the big things already, but I'll talk a little bit about my own experience. Let's see. So this is actually not really going to be the topic of what I'm going to talk about, but it's a saying that people say when you go into the humanitarian field, the people you meet are either missionaries, mercenaries, or misfits. And I guess the way this relates to the point I want to make is that life in humanitarian work is unpredictable, and you don't know what you're going to come upon. And that's sort of been the story of my personal journey too, I guess. Let's see how this goes. Okay. So a couple years ago, there was this meme going around with like a series of photos of what your mother thinks you do, what the public thinks you do, what your friends think you do, what you really do. And I wish I could say this is what I did all the time. And when I was a Peace Corps volunteer, I did a lot of this. But the reality of what I do most of the time is more like this. as a senior technical advisor at the headquarters, one of my colleagues says we save babies by email. And that was a choice of mine. Had I stayed in the field, I could have been hanging out with pregnant moms and babies. But I made a choice to move to headquarters because I wanted to come back to DC. So there are options. You could be in that place. But even when I was in the field, as a coordinator running programs, I still spend a lot of time in front of my computer, I'll be perfectly honest. So what do I do as a senior technical advisor? I manage a team of other technical advisors. I focus now primarily on health research, so I manage a portfolio of research advisors who lead research projects that are related to our programs. We often work with academic partners, doing everything from large-scale impact evaluations to formative research, operational research related to our programs. We've done, big mortality surveys, all sorts of different things. That's what I do. I'm temporarily also supervising our child health and our mental health and our nutrition teams as well. But we're in the midst of restructuring. But again, this goes back to the unpredictability thing. You don't know what's going to happen. You may end up supervising different people and learning about new fields that you never expected you would be working in. I do have a background in nutrition and child health, but the mental health thing is totally new to me. So this was, me in Peace Corps. So after college, I joined the Peace Corps. I was an English teacher, but that's when I decided I wanted to go into public health. I realized I did not know anything about healthcare. I had never worked in the health field, and I felt that it would probably be difficult for me to tell people how to run health systems, having never worked in one. So I actually came back and enrolled in the accelerated nursing program here at Hopkins, and did that and applied to the master's program here while I was there. After 13 months in nursing school, I realized I didn't actually know how to do anything either, so I deferred starting my master's program here and worked in the hospital across the street for a year, which was actually probably one of the better choices I made in my career, because it meant that I worked in the hospital for the next 4 years while I was doing my master's and PhD, and that funded my existence for those 4 years, so I didn't have to take out all those loans that Gilbert was talking about. One of the ironic things is that, again, going back to unpredictability, when I was in nursing school, I knew I was going to be doing a master's, and so I actually took Gilbert's course, Introduction to Humanitarian Emergencies, and it was a great course. I enjoyed it. However, I realized at that point that I really wanted to go into working in community-based prevention, and I didn't want to go into humanitarian work. I didn't want to be dealing with disasters after they happened. I wanted to work on the prevention side. So the fact that I'm doing what I do now is obviously not what I planned to do. During my master's, I shopped Gilbert's refugee health class, and I said, well, I'm never going to work with refugees. I want to go into community-based prevention work. So I never took refugee health care. My first job, as you'll see in a bit, after leaving Hopkins, was working in a refugee camp. I probably should have maybe taken that class. There's other classes that I took here. For instance, a class that I never thought would be that important. It was just a requirement to take an environmental health class here. So in the year between doing my nursing degree and starting my master's, I knew I was going to have to take an environmental health class. The global environmental health class at that time was, I think, 5 credits. Tropical environmental health was 2 credits. So I figured I'll do the 2-credit class. I don't care about environmental health. I'm just going to do this. It happened to be, it was 8 classes, right? It was just during one quarter. 2 of the 8 classes were scheduled the morning after I had to work a 12-hour night shift in the hospital. I don't remember what happened in those classes, so basically I missed a quarter of the course. A number of years later, I ended up supervising a team of about, 25 environmental health staff who were drilling boreholes and putting in water points and teaching people about hygiene. So you really never know what's going to be useful in what you take here and what you don't. So I would say just take whatever classes are interesting to you, because it may be totally irrelevant later on. So after nursing school, I worked across the street in the HIV unit for a year, came here, did my master's in social and behavioral interventions. Again, at this point, I was thinking I want to do orphans and vulnerable children. I'd worked in HIV, wanted to do preventive work. I didn't want to take an unpaid internship for my field placement. Joel Gittleson in the nutrition department had an opportunity to do research in First Nations communities in Canada, which involved being paid. I said, that sounds great. I love Canada. Working with minority populations, great. So went to Canada, ended up staying for another 4 years doing my PhD with Joel working in Canada, which people would laugh at me because they'd say, you do international health, you're going to Canada? anyway, First Nations, like American Indian nations in the U.S., are sovereign nations. So technically, yes, I was doing international health, and it was a great experience. I really enjoyed working in these communities. I was working on diabetes prevention, obesity prevention, which again, for about 10 years was not particularly relevant to what I was doing, but now NCDs are the big thing in humanitarian crises. So that did actually become useful because I know something about diabetes prevention. So after I finished my dissertation, I decided to go on vacation. One of my classmates was still working on her field research for her dissertation in Tanzania. I went to go visit her, and I was planning to volunteer for a few months. At that point I was still working actively as a nurse in clinical settings, so I figured it'll be easy. I can go for a few months, volunteer, then I'll come back and get a regular job in the US doing obesity prevention or whatever. So someone from my PhD program who graduated ahead of me, she was in Tanzania volunteering with IRC, and she said, oh, you can come do this. I'm working in a refugee camp doing community health. So I met with her country director, and he said, well, I've got this job for you. And I said, I don't want a job. I just want to volunteer for 3 months. I can do this, it'll be helpful. And he said, no. And so we negotiated down to 6 months. I was working on an avian influenza project because I had a background in infectious disease. It was a surveillance project in the camps because they were worried that, I guess, avian flu might come across the border because of the migration. After 6 months, the head of our field office there, this is in western Tanzania with Burundian refugees, was promoted to become the country director, and they said, well, do you want to run the field office? So I said, sure, and I stayed another year, and we're about 10 years down the line now. I'm still working for IRC. After that, I went to Cote d'Ivoire. Then I worked for a while in our Switzerland office as part of our headquarters, providing technical support to our field programs. I worked a lot in DRC, and then recently switched over to doing research. Just to give you a little bit about IRC, in case you're not familiar, our mission is to help people whose lives and livelihoods are shattered by conflict and disaster to survive, recover, and gain control of their future. So in terms of the population we serve, it's actually not all refugees. A lot of people think all we do is refugees. We actually have a spectrum sort of immediate emergency to maybe 10, 20 years post a crisis. But in terms of the people, it's people who are forced to flee. We also serve the host communities that support them, and as well as people who are affected by conflict who don't actually leave their homes. In terms of where we work, it's this intersection of where there's a disaster or conflict, where there's poverty and exclusion, and where there's weak capacity, will, or legitimacy of the state to provide services. So for instance, we don't really work in Latin America because there most governments are able to deal with any crises that aren't enormous. A lot of East Asia, the same thing. We have limited programming there because there the state is usually able to respond and deal with crises. So the places we work are largely sub-Saharan Africa, of course the Middle East right now, and a little bit in Asia, like in Pakistan, Afghanistan. And the areas that we work in are not just health, but the outcomes that we're focused are on safety, which is mostly protection programming, education, economic well-being, and power as well. And what I would say, I would definitely reiterate what Carolyn said. I have a job mostly because I studied French in elementary school and middle school and didn't speak it for about 10, 15 years, but someone decided that it would be okay to give me a job in Ivory Coast just because I sort of spoke French, but speaking French really opened up a lot of doors, particularly for an American organization. If you go work for French NGOs, I'm gonna help you, but for American organizations, a lot of Americans don't speak French, and a lot of the crises happen to be in Francophone countries. Obviously, if you speak Arabic these days, also very important, particularly in health, because in a lot of organizations, there's a lot of healthcare personnel in the Middle East, so most of our staff are local, whereas in other sectors, like in cash programming or things like that, you have more expat staff. So if you want to work as a technical advisor, you need to be able to speak Arabic because all our field staff are Arabic speaking and may or may not speak English. So language is definitely important. And going back to sort of the unpredictability, the flexibility thing. If you're willing to go to some country that you've never heard of and the places that people don't want to go early on and get the field experience, that is key. And it's easier to get jobs in the places that no one wants to go. If you want to be based in, Nairobi or in some nice capital, you're competing with a lot of people. But if you're willing to go to Central African Republic, and that means you speak French and you're willing to go live in really pretty poor conditions, you're more likely to get a position. So flexibility, and I mean, it's great if you know exactly what you want to do and you're driven, but honestly, if you're willing to do whatever opportunity is in front of you at the moment and get that field experience, it counts for a lot. I would say if you want to be at the headquarters as a technical advisor, usually you need at least 2 or 3 years of field experience actually working in humanitarian programming. There's exceptions, but it counts for a lot. And yeah, I think that's about it.
Okay, good, very good. Laura, thanks very much. So, a couple quick questions for Laura, and then we'll go on to talk to Linda. Okay, anything that comes to mind you'd like to ask?
Can you answer the question that we asked from her earlier about what kind of new skill sets do you think people are not coming in with, and what would be?
Sure. Again, so it really it depends. So like within IRC, I said we do a broad range. We do everything from the acute emergency on the ground in 72 hours to the 15 years post-conflict programming. If you want to do acute emergencies, you really need to have clinical experience. We are sometimes providing direct services, and there are cases we have people who go in to manage programs who don't, but if you're going to set up a field hospital, if you're going to run an Ebola isolation unit, you need to have clinical experience. That does not hold true for the more post-conflict areas where you're managing programs and it's more about dealing with proposals and dealing with negotiating with the Ministry of Health and things like that. I mean, that said, it still does help because when you meet people from the Ministry of Health in any country, they're going to be doctors largely. So having that clinical background helps. It's not absolutely necessary, but it really does help. I mean, going to nursing school is one of the sort of unexpectedly good choices that I made that I didn't really know at the time was going to help me. So that, it depends. I mean, there's also roles, in monitoring and evaluation. And so sometimes we need people just to do that, in which case you need good skills with dealing with different data platforms, dealing with indicators, measurement, things like that. So there's different niche areas. The other things, really the field experience. I mean, having done Peace Corps helped. Some people, I wasn't working in the humanitarian world, but it means that you can survive 2 years living in a hut somewhere. And people who are familiar with that will take that into account. The languages. The other things, I think, most often what is often needed, depending on the country, depending on local capacity, is that it's usually not hard to find local clinical staff, right? You can find doctors and nurses, with the exception of a South Sudan or something like that, or a CAR. Often what those clinicians don't have is management experience, program management experience. So we often do hire less experienced, younger people to do program management because they need to be able to write proposals, they need to be able to write reports, they need to be able to manage a team of people. So those management skills are not always something that local staff who are clinically trained will have, and that's something that you can offer. So if you have good experience doing program management, dealing with huge budgets. So that's something that actually a lot of health people don't like to do, is deal with budgets. It's not something that if you're a doctor, that's not necessarily what you do. But the fact is, if you're running a program and not running a field hospital, part of your job is managing millions of dollars worth of budgets. So again, it depends on if you want to do emergency response, you don't need to worry about that as much. But if you're going to if you don't have a clinical background and you're going into managing programs, you have to know how to manage budgets and deal with an Excel sheet and report on things. Does that answer the question?
Yeah.
Okay.
Let's take one more question, and then we'll go to Linda, and then we'll save your questions for later on here. Yeah.
Can you speak a little bit about the role of research in humanitarian settings, collaborations, and what that looks like?
Sure. So one of the reasons why IRC has decided to invest in research and make this point is there's actually very little evidence in humanitarian settings, particularly for fields outside of health. So we did systematic reviews of systematic reviews for all our 5 outcomes, and our team found. In health, they found something, this was not just in humanitarian settings, in all settings. They found, I think, like 3,000 systematic reviews for health, related to protection or safety, there were like 200. So there's a dearth of evidence for a lot of other outcomes in humanitarian settings. But even in health, there's just a lot less evidence in humanitarian settings, in part because it's really difficult to do research in a humanitarian setting. So this is we decided that we need to generate evidence. Things happen differently in humanitarian settings. We can't rely solely on data that comes from development settings, and we want to be data-driven. There's this whole movement around aid effectiveness and better aid means that to do that we need evidence, particularly on cost. Cost effectiveness is a big issue now that's floating around, particularly in the atmosphere of potentially constricting budgets. Being able to do more with less funding is something that is being asked of a lot of implementing agencies. So we do everything from impact evaluations to just program evaluations, but having that information on what actually works and what's more cost effective and what will have larger impact is something that's important. So it's a challenge because people on the ground who are trying to implement programs and deliver results don't necessarily want to be bothered with a research team coming in and having to support a research team. And so it's a delicate balance between showing what the benefit of doing this research is, because sometimes for a large impact evaluation, it may not have an immediate benefit. Operational research, it's usually easier to work with country programs and explain to them why it's important, but for some of the large-scale impact evaluations, it can be harder to see because the benefit is more for the global community, not for the people right there necessarily.
But fortunately, we're seeing now an emerging interest in research
Yes.
in humanitarian affairs, and there's some grant funds available for this. So Laura, thank you very much for this. Okay, now to continue our theme of linear career planning, I want to introduce Linda Mobula, originally from DR Congo, but she finished her degrees pre-med in Arizona. Then she completed medicine at UCSF in San Francisco and had a real emphasis on global health issues there. Came here to do internal medicine, and while she was doing internal medicine, she did her MPH. And I first met Linda in detail when she came to me saying she was really interested in non-communicable diseases in disaster situations. So following that, I think one of the first things was Haiti, dealing with the cholera outbreak in Haiti. Then there was a period of time dealing with the effects of Typhoon Haiyan in the Philippines. And then she went off to be involved with Ebola, another non-communicable disease. But now, finally, we're working together on a non-communicable disease program in Ghana, where she's the co-PI for this one. So Linda, and now I should say she's working for the Office of Foreign Disaster Assistance. She spent a lot of time in Guinea, being a native French speaker, being the kind of interim or the kind of country director for the OFDA program in Ebola in Guinea, and has lots of stories to talk about that. So anyway, we'll turn the time over to you, and you can tell us about how you got to where you are and where you see the opportunities for people thinking where to go next.
Thank you, Gilbert. So I'm going to talk a little bit about my journey. So as Gilbert mentioned, I was raised in the Democratic Republic of the Congo. So I was born in the States and moved to the Congo and was there during the onset of the war in '97, and was really affected by it because I realized that I wanted to work in humanitarian settings. So I decided to go to medical school because I thought I should become a doctor, work in Africa, DR Congo or other countries, and that's a way that I could help contribute to solving some of these issues. So went to medical school, did a couple of rotations overseas, so went to the Congo, spent a couple of months there in the field doing research as a medical student. Then I graduated from medical school, did residency here in Baltimore at Hopkins, and during my residency, the earthquake in Haiti occurred, and I decided I wanted to go volunteer. So a couple of months after the earthquake happened, I volunteered at a primary health care clinic in a large slum in Haiti and spent about 2 weeks there, and we saw about 200 patients a day. So we treated non-communicable diseases like hypertension, diabetes, malaria, pneumonia, diarrhea. We saw everything. And I really fell in love with it. And so I decided to go back during a vacation, and I spent an additional 2 weeks there, and that's when the cholera outbreak started in October 2010. And we really struggled to find healthcare providers in Haiti that had experience treating cholera. This was the first time Haiti had been struck by a cholera outbreak in more than 200 years, and it was introduced by Nepalese UN peacekeepers. So provided clinical care to cholera patients and kept on going back and was really intrigued by how challenging, or was really interested in how challenging it was to solve some of these larger public health issues. So I finished my residency, moved to Haiti, and ended up managing a health program. And as both Lara and Carolyn mentioned, I think having management experience is extremely important because I had none. So I had to manage a budget, I had to write a proposal, and they don't teach you that in medical school. So really learned by trial and error. So wrote a couple of proposals, managed a budget for the clinic that I had previously worked in, worked on maternal child health, managed this cholera treatment unit, cholera treatment center, and had to transition the cholera treatment center back to the Ministry of Health. So actually received funding from the organization I now work for to manage that center. But once the disaster was actually over, we had to ensure that the Ministry of Health had the capacity to actually manage this treatment center. So prior to moving to Haiti, I had actually agreed to do a postdoctoral fellowship here at Hopkins and was enrolled in the MPH program. Luckily, Hopkins agreed to defer my enrollment, so I spent a year there, wanted to stay longer, but had to come back, and did my master's in public health, and that's where I met Gilbert. And we worked on several projects together. Worked on a project looking at preparedness for cholera outbreak response in Haiti. Then worked on an NCD project, which was my original interest, because I'm a primary care physician. So then, Typhoon Yolanda occurred in the Philippines and was asked to go help respond. And I spent 2 months in the Philippines responding to Typhoon Haiyan and ended up again managing this project. So organized mobile clinics in areas that were affected by the typhoon, but also worked on a cholera preparedness plan. And so that involves having good writing skills. So here we go again, right? So managing budgets, program management, writing proposals. Very important skills. So came back, then went to Ghana, worked on this research protocol for this project that Gilbert and I are still working on. And it's a private-public partnership between the Gates Foundation, pharmaceutical companies, Hopkins University, and the government of Ghana. And we're doing this prospective study looking at hypertension and diabetes outcomes among Ghanaians. So started working on that during my fellowship. And as much as I could, I actually tried to publish, collected data from the Philippines, collected data from Haiti, tried to analyze that data and published it. So somebody asked a question about research. There's very limited evidence in humanitarian settings. So Gilbert and several of my other advisors told me it's important to collect data if you can and try to publish it. So that's what I did. So at the end of my fellowship, I was trying to figure out what I wanted to do, whether I wanted to stay in academia, continue to do research, or work for the government. So I ended up applying for a position with USAID and worked as a technical advisor with the HIV office. And I was supposed to start in September. In July 2014, was working on this project in Ghana and got a call from Samaritan's Purse asking if I would be willing to go to Liberia to respond to Ebola. And I thought about it for a few days thinking, I'm starting this new job, I should probably get some rest, go on vacation. But I said yes, and I went to Liberia. As soon as I arrived, the first thing I was told was, there's a physician whose name is Kemp Brantley who just developed symptoms. We don't know if it's Ebola. It's very likely that it is. We just did blood tests. We'll find out tomorrow. he ended up being positive for Ebola. And I took over some of his responsibilities and managed the Ebola treatment unit that Samaritan's Purse was running, and worked very closely with MSF. And at the time, we were the only NGO working in Liberia, and ended up running this Ebola treatment unit, and the caseload of Ebola just went skyrocketed during that time. And there was limited engagement, limited involvement in the humanitarian community at the time, because prior to July 2014, Ebola had largely been managed by MSF, the World Health Organization, CDC. There was no need to have a humanitarian response to Ebola because the outbreaks were very limited in size and largely occurred in rural areas in the Democratic Republic of the Congo. In fact, there was an outbreak when I was a child, about 200 kilometers from where I lived. And also, I think having U.S. citizens become infected really impacted what the government kind of thought about global health security and how it would impact the United States. So we evacuated both Kent Brantley and Nancy Rifle back to the United States, and I started my job with USAID a couple of weeks later as an advisor for the HIV program. So fast forward, so the Office of Foreign Disaster Assistance basically activated a disaster assistance response team for Ebola in August 2014. And they were primarily based in Liberia, but then expanded to Guinea. Because I spoke French, was asked, and have a health background, was asked to participate in the DART team. So I went to Guinea for about 6 weeks as a health advisor. And they asked me to go back again and again and again and again. And I ended up moving away from HIV and working primarily on Ebola as a health advisor initially, but then became the deputy team leader and then the acting senior humanitarian advisor. And currently I work as a public health and infectious disease advisor, and my role consists of providing technical assistance to the office. So what I do is I review proposals that are submitted to OFDA for funding to ensure that technical standards are met. So I cover several countries. Guinea, number one, because I spent more than 7 or 8 months there. But also DRC, I asked to cover DRC, and Nigeria. So in the northeastern part of Nigeria, there is a conflict due to Boko Haram, and we are providing funding for health, water and sanitation, hygiene, shelter, cash, and the list goes on. So it's a multi-sectoral response. So I've been to Nigeria about twice. I went to the northeastern part of Nigeria and visited a couple of camps and provide technical assistance for some of our health programs. In addition to that, have worked in a couple of refugee camps in Greece, actually. So not with the U.S. government, but with an NGO. So I've done a couple of things, like a lot. And so there's academia, there's implementation in the NGO world, but also clinical medicine as well. And now I work for the government. And it's interesting because I like to be in the field and I like to be on the ground, and it's hard not being able to actually provide clinical care or to interact very closely with beneficiaries. So we spend a lot of time in an office where we have lots of meetings, phone calls with our regional offices in different parts of the world. We meet with a lot of non-governmental organizations, with UN organizations like the World Health Organization. We have a lot of meetings with CDC, for example. So the way our office is actually built up is we have regional teams that work in our 5 regional offices. So we have a regional office in Dakar. We have a regional office in Bangkok, Thailand. There's one in Costa Rica. There's one in Nairobi. And the 5th one is in Bulgaria, I believe. And so those regional offices basically manage funding for various programs throughout the world. We have, I think, 4 or 5 disaster assistance response teams that are activated to respond to humanitarian crises. There's one in Nigeria, there's one in South Sudan, Iraq, Syria, I think those are the 4, and Yemen. Yemen is the 5th one. So we have a very large group of people that work both in DC and in the field, And our job is to really coordinate humanitarian emergencies with the rest of the US government. So we work very closely with the State Department, with the National Security Council, with the Centers for Disease Control. There's also a division within my office that works on policy. So it's called the Humanitarian Policy and Global Engagement Division. So they work very closely with World Health Organization, with Interaction, with CDC, State Department, and the list continues. One of the projects I've been working on for the past year consists of actually building capacity to respond to public health emergencies like Ebola. So Ebola was the largest infectious disease outbreak that OFDA responded to. So FDA typically does not respond to large-scale infectious disease outbreaks. OFDA had responded to cholera, but also to H1N1 in 2009 by doing procurement of personal protective equipment and of antivirals. So during the Ebola outbreak, OFDA spent more than $800 million providing funding to UN organizations and to NGOs, but also coordinated the US government response by working with CDC and the Department of Defense. So as a result of Ebola, we're looking at lessons learned from Ebola. So what if there were another outbreak that were to occur? Will Ebola become a humanitarian emergency? Maybe, maybe not. There are certain things like there's a vaccine now. There's ZMapp, which is used to be an investigational drug, but was actually investigated in a trial. So there are different tools that we have now to respond more effectively to Ebola. You know, one of our concerns is actually pandemic influenza. So the threat of H7N9 in China is very high. So if H7N9, which is an airborne disease, were to become human to human and were virulent, multiple people would die very rapidly. But how do you respond to that? And how do you ensure that we as an office, that we're prepared, that the rest of the US government is prepared? So those are conversations that we've been having with other parts of the US government, but also internally as an office. So I will stop there and see if there are any questions.
Right. Okay, so we have some questions specifically for Linda, and then we'll open it up to the other questions that are still in the question bank.
Thank you to all the speakers for sharing your background. I had a quick question, and I apologize if this is a little bit of a personal question, but I was curious if you could comment on what you felt and what the environment was or feeling was when you were there serving the Ebola epidemic, and then you would hear people in the U.S. saying anyone who goes abroad and comes back should be quarantined for 21 days. If there were any mixed feelings about that, if there's a discouragement to go work there, anything like that.
So because I had colleagues that had contracted Ebola, obviously I was scared I would get it. And I ended up treating them, which increased the risk of actually contracting it. Definitely lots of fear, I will not lie. But also a sense of, I would say, discouragement that we had arrived to that point. But also hope that the humanitarian community would come together to respond, which it did. To answer your question about quarantine, at the time, so in July 2014, there were not, I guess, policies at the level of the US government regarding quarantine, and so we worked with CDC, and I wasn't a government employee at the time, so worked very closely with CDC and MSF to ask them what they had done previously. And MSF's policy was, for previous outbreaks, as a healthcare worker, you would return to your country and you would just reintegrate. And if you developed symptoms, you would monitor your temperature twice a day for 21 days. And if you developed symptoms, you would isolate yourself and present to a health facility or to a hospital. So when we came back, there's a lot of fear because I think on the part of just the general public, because the fact that Kent and Nancy were sick was highly publicized. So there were a group of people that ended up staying in Atlanta for a couple of weeks, for 21 days, just in case they developed symptoms, they could go to Emory for care. And I had spoken with Hopkins, and I explained my situation and said, if I were to develop symptoms, are you capable, are you willing to care for me? And they said, yeah. So that was my plan. I wanted to make sure that if I were to get sick, first of all, didn't want to infect anybody, but just wanted to make sure there was that capacity to treat me. So spoke with CDC, and they told me to check my temperature twice a day for 21 days. So fast forward, the US then developed a policy, I think Homeland Security developed a policy where, working very closely with CDC, basically requiring that everybody that came back from West Africa had to fly into it was either 2 or 3 airports. So Dulles, New York, Atlanta, Newark might have been one of them, and I can't remember what the 5th was. But you had to be screened, and you had to check your temperature twice a day and call the health department every day to report your temperature.
Or if you didn't call, they called you.
They called
I mean, I can tell you, I got into a fight with a very good friend of mine. I was in Sierra Leone twice for about 2 months in total, and I wasn't working in clinical capacity, but yes, I got into an argument with someone about my return and being in contact. I was involved in recruiting where we ran several isolation units, and this compared to other humanitarian emergencies, this was incredibly hard to recruit health staff for multiple reasons. One,
Yeah.
people themselves were scared because we had a longtime Sierra Leonean staff logistics guy, not a health person. He refused to go to Sierra Leone because he lived in the US, and he knew as a Sierra Leonean coming back to the US, he would be basically stigmatized. Some countries in sub-Saharan Africa had restrictions on people coming back, so a British nurse living in South Africa could not return to South Africa after having worked in Sierra Leone, so she could not take the job we offered her. There were other people who said for family reasons they refused to go work in the isolation unit. So lots of staff that we normally would have called on were not available, and it was a huge. A lot of it had to do with the media hype and sort of.
Yeah, it's very interesting.
It was interesting for me because I had just been out in the field for, I guess, 2 years when this all happened, and a lot of my old staff, including some of my national staff certainly, but some of the local partners that we had built the capacity out of Pakistan went.
Yeah.
And
engineers.
yeah, and again, I'm not a healthcare professional, but I'm great at managing people and doing capacity strengthening. And it killed me that I couldn't go and be supportive.
Yeah.